welcome to our presentation on health system simulation modeling and their impact on insurance. My name is Aachal and I'm joined by my partner Preston.
Hello, this is Preston. This presentation will give a brief description of insurance, then we'll get into some of the problems that professionals have been working on in the last 10 years, though some go back even further. Some of these have potential solutions which we'll highlight, and some will require further research.
For this project, we're looking at purchasing, utilization of, and optimization of insurance and its effect on the workflows of healthcare workers and the ways and means patients move through different healthcare systems. We are not going to be diving more inside the insurance companies, which will be more in our paper, but for the moment, let's widen the scope of it. What is insurance? I'm pretty sure everyone is aware of it, but in simple terms, insurance is an arrangement to protect yourself from any possible eventuality.
That's succinct. However, health insurance is more complicated, unfortunately. First, health insurance might be assumed to handle all health-related issues with the body and mind. In America, health insurance is about the care of extremely specific parts of the physical condition of the body. Notice, that definition does not include mental or behavioral health. It is also exclusive of dental and vision insurance, which is why we use the limiting adjectives in that descriptor. This is further aggravated by the silos of care. It's a term we use around the office and which literature borrows as well. It means that different parts of this already intricate system do not communicate well with each other. We'll discuss that more in just a second, but what about the patient-facing side of health insurance? At least as much as it can be discussed within the confines of this project.
Let's go quickly over the main type of insurance, as most of us should be aware that there are public insurance or private insurance, where under public insurance includes Medicaid, which is for low-income individuals, and Medicare for people who are 65 and older or with a disability. On the private side, there are employer-sponsored plans where your employers help cover the cost, and individual plans available through exchanges, like health exchange markets. Next, the type of insurance plans are HMO, PPO, EPO. And to manage these costs, we have HSA, FSA. Moving forward, there are metal tiers to it, which is bronze, silver, gold, platinum. As you see, I'm throwing so many other words. Health insurance is as complicated as it is. But it is very important that you choose the right insurance, which you can depend on based on your budget and best care that you need for. So, to further explain, I would recommend you guys to watch the video that's linked above, which gives you clear and more detailed information about these acronyms that I just threw in front of you.
Returning to those silos of care, where different institutions are not communicating efficiently, I want to clarify that these are first-degree relations that are making decisions that affect other parts of the system, and which are not communicating these changes well. The decision makers frequently do not have a proper background in healthcare, nor are they involving authority figures to weigh in. And even when we succeed in modeling and simulating the systems of healthcare, unfortunately, simulations at one location never appear portable to another site. Instead, each location must create its own simulation, meaning that the whole modeling effort must be replicated. This is also known as Not Invented Here, or NIH, from Robert's tutorial on the simulation of healthcare systems. Freebarn et al., in Simulation Modeling as a Tool for Knowledge Mobilization in Health Policy Settings, a case study protocol, elucidates. Descriptive evidence and analytical studies are used to describe issues and inform priorities. However, evidence on the implementation and impact of interventions is less commonly used to inform program planning decisions and strategic actions. In some cases, program decision-making can be driven by informed guesswork, expert hunches, political and other imperatives. Policymakers require synthesized and localized data that contrasts and prioritizes policy options. demonstrates effectiveness of interventions, demonstrates the need for a policy response, demonstrates cost effectiveness of actions, reflects the level of public support for a particular issue, and personalizes the problem. These systemic issues affect how healthcare providers treat their patients, often having to choose between quality of care, time spent, and cost of visits. And they maintain barriers of care for quality of life improvements or even treatments of serious diseases. It's not much better on the patient-facing side, but Aachal has a couple of tools currently in use that might help you, and hopefully better solutions will show themselves later.
So I don't know about the solutions yet, but there are definitely tools that are being modeled for us to use for better outcome, or let's say for choosing the better insurance plans. First, the health insurance premium calculator, which estimates costs based on factors like age, location, health, and more. And how in health system simulation modeling, this calculator tests different situations to see how things like getting sick or needing more care can affect your insurance cost. It helps you compare different plans and pick the one that's just right for your needs. Then there is actual life table. This table shows the likelihood of illness or life expectancy by age and gender. This table shows the math of how likely it is for someone of certain age to get sick or live longer. The simulation modeling uses this table to understand health risk based on age and help insurance companies know more about how much to charge you. Together, these two simulate real-life scenarios, helping predict cost and risk, so individuals and providers can make smarter and data-driven decisions about health insurance.
But quickly, Aachal, what is this equation here at the bottom of the screen?
Actually, among various mathematical models that actually use, this is one of the examples for decision making.
Oh, cool.
And moving forward onto the solution code. As per our literary review and current research in health system simulation modeling, several solutions are being implemented to enhance healthcare efficiency and insurance practices, among which I would like to grab your attention towards the AI and machine learning. As you know, with the today's generation, the role that AI plays and insurance is no different. AI and machine learning based pricing models are being implemented to provide more accurate and personalized insurance codes. As per our research, we even found that there are models which perform 20% better than the insurance carrier's existing pricing model.
And I want to dive a little further into an older scheme being reinvented: vertical integration. Diebel's dissertation, Essays on the Market Structure of the U.S. Healthcare System, speaks on this and vertical bundling as potential efficiency-inducing practices. The author investigates how these practices between hospitals and insurers affects market outcomes and welfare, modeling said market, and simulating factual and counterfactual scenarios. Diebel finds that removal of existing vertical integration from the market decreases consumer welfare by $9.5 billion a year. The author admits that a lack of vertical integration is somewhat better financially for hospitals and insurance companies. However, findings show that due to competitiveness between these institutions, only some do better while others suffer. It is also important that much of Diebel's findings are predicated on the existence and enforcement of the Affordable Care Act, which went into effect in 2010. The ACA puts regulations on the healthcare system by the government, and those institutions that are actively engaged with vertical integration measures as put forth by the ACA are not suffering financially. There is a lot more work to do. Speaking of, let's get into further research that's needed. Aachal?
Well, we highlight the areas where more research could enhance health system modeling. From the literature, we've seen a need to explore how comorbidities affect individual health, how job markets shift influences insurance access and use, and how to build a fair, interpretable models that combine big data and traditional methods. Looking ahead, we'd like to see more studies comparing corporate risk models to patient care, identifying barriers to preventive care, and exploring hybrid models that blend actual science with machine learning for better risk prediction. So having said that, Smart insurance isn't just about coverage, it's about understanding the data, predicting needs, and offering the solution that evolve with time.
And my thoughts can be summed up in these two quotes. This thing we call the healthcare system, I would agree with Cronkite. It's not a system. It's a potpourri of entities that all talk about how the system doesn't work, and the entities writing checks that want a lame system because it's more beneficial for their financial bottom line. We hope this has been a useful or informative presentation for you. For further reading, please check out these resources, which will also be linked below.
Thank you.